Oh, there's my audio. All right. I think we're about ready to start. We have a few people still coming in, but I think we can get going. Thank you, everyone, for coming to another edition of the MONK-POSIUM, Medical Monks Monthly webinar series. This month we have a very special guest. We have Chrystalbelle Rogers. She's a certified wound care nurse and certified in executive nurse practice with a master's in nursing administration from Southwest Baptist University Mercy School of Nursing. A little bit about her. Throughout her nursing career, she has served on several facility and organization-wide committees as facilitator and chair, with the aim of improving client or patient outcomes, and pressure injury prevention, wound care, quality, shared governance, clinical practice, and survey readiness. She is currently the Director of Clinical Services at HartmannUSA Incorporated, and we'll be getting going in just a moment. I just want to mention very quickly, we will be having a presentation from Chrystalbelle in just a moment. Right after, we'll be having a brief Q&A. So if anyone has any questions about the presentation or anything about the topic generally, you can go ahead and put your question over in the chat. I will be monitoring the chat during the presentation. So anytime anything comes into your head, you can just put it over there. I'll be making note of it, and we'll be doing the Q&A at the end. So without further ado, here's Chrystalbelle. Take it away.
Thank you, Adam. I really appreciate the intro. Usually I would just say I'm Chrystalbelle Rogers. I'm the Director of Clinical Services for HartmannUSA, and I am a certified wound care nurse. I love my job as a wound care nurse, and so I feel very fortunate to be able to share this information with you today. So with that being said, I'm going to get our presentation started. First of all, I just want to take a moment to talk about wound balance in general. So wound balance is a document that came out back in April. It was a document that I had actually never heard of the concept myself. And when I found out about this document, it really intrigued me. So I thought, well, I want to learn more about this. And certainly since that time, we have had a lot of people reaching out to us to learn more about this concept. So I'm glad to share this with you all today. So our learning objectives today, first of all, we're going to talk about the key concepts in the wound balance continuum. We're going to talk about the science of wound healing, the healing trajectory, and then we're also going to talk about, most importantly, the impact on patient-centered care and quality of life. So, like I said, this document came out in spring, and it came out due to the efforts of 12 experts. This was done in Germany, and it was actually done last year. The goal of this document was to create a consensus document that would drive appropriate wound care for all clinicians. This happened in Frankfurt, Germany, back in 2022 in the fall. And these folks were not just people who maybe we're used to hearing from. There were a lot of different experts in a lot of different areas all across the globe. And so it really makes this document speak to everyone. So within this document, there were several concepts that arrived after a pretty deep discussion and a deep dive into what it really takes to heal a wound. And when the discussion started really getting deep, they realized there were three key concepts. One of them being clinical practice, the other one patient care practice, and then finally wound balance. And you can tell by the circles in this model that there's actually meaning behind all three of these and where they're located. Wound balance being the foundation. So when we look at this from a clinical perspective, we're talking about those daily functions that we do as we're taking care of a patient, providing wound care. So it's really the foundation. The second circle is the patient-centered piece. I think it's really important that it's in the middle, just where it's located, because after all, that is the most important part of our care. And then finally, clinical practice, which is more all-encompassing. So that's when we're looking at how do we really implement both the great wound care practice, evidence-based, of course, and then also include that patient balance piece, which is so important because we know those barriers can hinder any great wound care. So what happened is they ended up coming up with a few really key concepts. You can see from this model here that the information that they provided really touched all factors, and they were interrelated. So they came up with a few concepts that were really important, including removing the barriers, balancing the healing trajectory, balancing patient care and quality of life, and then finally clinical practice. These were the points that really stuck out. And then I think there's still some other concepts in here that probably will end up coming to light later on. But what really happened after all of this is they identified 3 key areas, and that's where we come up with the idea of these concepts of wound balance, patient care balance, and clinical practice. And that's what you saw in the previous model with the 3 circles. And all of these factors included things like wound research and biomarkers, patient-centered assessment and diagnosis. And you'll see later on how that is intertwined in several different areas. Patient experience, we all know that that's super important. And then impact on clinical decision-making and practice continuity. And then finally, again, the patient being at the center of it all. So for me, I think this was the most important part of this document. When we look at how we treat wounds today, most oftentimes we talk about managing wounds, especially in some care settings. We recognize that maybe our focus isn't always on healing a wound, but maybe it's just managing in the moment because we're with that patient for such a short period of time. However, this document really points to the intention of healing wounds whenever possible and as early as possible, and really leveraging that. So that doesn't necessarily mean that that's always going to be our absolute goal, but what that does mean is by doing those things that are intentional to heal a wound, we're going to benefit the patient, even if that isn't their goal. So there were actually 3 main categories of barriers. When you think about barriers to wound healing, I'm sure everybody on this webinar today can think of some things that maybe aren't on this list, but are really important. And you've seen them day after day in your care and in your practice. But there are 3 main areas, one of them being the wound itself, or the clinical aspects of the wound itself, including those local inhibitors to healing, systemic inhibitors to healing, and then finally that normalization of the wound healing. And then the patient. Those barriers can really vary, and it depends on your care setting. It depends on the patient. It can depend on their social determinants of health, or perhaps even their literacy level or their caregiver's literacy level. There's so many factors that can go into this. Or how about if they're housed or unhoused, or if they're working or not working? There's so many factors that can go into this piece. And that's the part that I liked about this document the most, is that it really is speaking to that patient-centered piece. And then finally, we also have the focus on wound management being one of the barriers. And again, we talked about that earlier, how having that intention to heal is extremely important. Oftentimes we miss the early signs of chronicity, especially as that patient goes throughout the continuum of care. We as providers or clinicians are oftentimes very habitual in our care. We get extremely comfortable with a product or a process, and we know that it's not going to harm the patient, or perhaps it seems to benefit the most or benefit the whole. But we also have to recognize that when we do that, that we might be missing the point for some of our patients whenever it comes to individualized care. And then finally, we want to make sure that we have effective training or education. And oftentimes that's a huge barrier. We know with staffing and all of those other issues that we're facing today in all of our care settings, that training and education are oftentimes the most difficult of situations. Not to mention the fact that we also have to train the caregiver or the patient to help provide some of this care for themselves as well. So when we look at this model that this group came up with, there were a couple things that were really important. And wound research and science translation of biomarkers were obviously the key point for the basis of science of wound healing. So when we look at the science of wound healing, what we'll notice is that, first of all, we do have three main areas. The first one being the systemic inhibitors of wound healing, the second being the local inhibitors of wound healing, and then finally the normalization of wound healing. And when we start walking through all three of these, what we're going to see is that, first of all, we have when we look at the patient as a whole, I love telling stories about this because every single patient is a little bit different. But when we look at their comorbidities, there can be lots of things that are hiding. And those are really those systemic inhibitors of wound healing. Perhaps it's venous insufficiency or some kind of vascular disease, maybe diabetes mellitus, diabetes type 2 especially. Maybe it's nutrition, or they have some kind of inflammatory disease, or maybe they actually have issues with pain because of some previous injuries. Carcinogens are a possibility as well, or even, recently we came out of the pandemic and we know that there were issues that came from people who did end up contracting COVID-19. And we see that frequently within our wound care as well. But the other piece of this is the red flags of chronicity. So rather than categorizing wounds as being chronic, what we're really looking at is maybe rephrasing that to hard to heal wounds. And clinicians should actively identify these red flags. There are some things that we can notice immediately that can impede healing, and that might be the patient's overall health status. It may be those comorbidities or underlying conditions. How about if they're high risk for infection? Or what if they've had other wounds for a long period of time? And yes, this might be a new wound, but we know that most of their wounds end up going into a chronic state. Or if the wound is actually growing in size or deteriorating, or having a deteriorating wound bed, or perhaps other areas located near the wound. And I think whenever we look at our care settings, we know that there's other red flags of chronicity. And oftentimes it may not actually have to do with their health status. It may also have to do with some of their social determinants of health, their living conditions, perhaps their financial conditions. It could be something that could be pretty simple to heal, but if they don't have the means to get to the things that they need, certainly those resources can be an issue, and they should be a red flag to us early on. And of all of the concepts in this paper, so that leveraging the intention of healing a wound and the red flags of chronicity are really the two key points. So making sure that we're acting early and that we are trying to provide that advanced wound care as early as possible with those patients who are at high risk. So we can't talk about wound healing without talking about the local inhibitors of wound healing, such as things that we can actually, technically, we can see, feel, and touch in the wound bed. So these things are quantifiable, although sometimes very difficult because they have to be done in a lab. But we know that MMPs exist within a wound bed, and especially the MMP2s and MMP9s. Both of those are obvious identifiers that there is a barrier to wound healing. Elastase from polymorphonuclear granulocytes. So we also call that PMN elastase for short. growth factors that are inactivated, or if there's matrix destruction. And these growth factors may actually be present in the wound, but oftentimes they're actually not doing anything for the wound. So they're inactive and they're just there stagnant. Or maybe there's other factors as far as inflammation goes that perhaps we can't see, but we do have ability to identify those. And then finally, when we look at angiogenesis, or that ability to regrow those little tiny vessels that help provide that blood supply, granulation tissue induction, and epithelial cell migration. And then finally, last but not least, is a nutrient or oxygen deficiency. We can't heal a wound without having those things addressed. So here's the interesting thing about MMPs. We hear lots of bad things about MMPs, but MMPs are actually necessary. They have to be balanced in the wound bed in order for that wound to heal. But remember, they do really important things, like they provide removal of bacteria. They help get rid of that damaged ECM or extracellular matrix. And that happens in the inflammatory state. Or during proliferation, we see the degradation of capillary basement membrane. For angiogenesis, we see migration of the epidermal cells. And then finally, also very important, we see with the remodeling. So when we're in that final state of healing, that contraction of the scar and remodeling of the scar. So MMPs do play a very important role. What we know is that our problems really run into when those MMPs get out of balance. And how do we know that they're out of balance? Well, there's a couple of ways. In some studies, they've been able to actually take a look at a wound and see how many MMPs are located inside of that wound drainage. And in this case, I really like this representation. It may be confusing with a lot of dots on the graph, but these dots all mean something. So each one of these dots actually represent a wound. And you can see in your very far right-hand side, it says acute wounds, and there's multiple dots there. But you can see that they're very, very low on the scale of MMPs. When you look at decubitus or pressure injuries, diabetic foot ulcers, venous leg ulcers, and arterial ulcers, you can see it's all across the board. And not surprisingly, with both decubitus ulcers or pressure injuries and venous leg ulcers, we can see that oftentimes it can be very high. And those tend to be the ones that become more chronic. So it makes perfect sense that those MMPs are higher in those wound beds. And so it's interesting to actually take a look at how MMPs work. And we'll talk about that a little bit more here in just a few minutes. But we can't go on without talking about the normalization of wound healing. So that's also very important. And there's things that have to happen in order for us to normalize wound healing. That includes angiogenesis. So again, that's that reoxygenation through those little tiny vessels, granulation tissue induction, epithelial cell migration, and then finally, we want to make sure that we're normalizing that inflammation. There's lots of different ways to do that. Sometimes it could be through antibiotics or other medications. Perhaps it's through some nutrition or treating some of the other comorbidities that these patients have. And then finally, changing the microenvironment toward normal wound healing. So with that, we're going to move on to balancing the healing trajectory. And you can see here, that actually is located in two areas of this model. So we can't talk about healing without talking about the patient. And we really need to take a look at that patient-centered assessment and diagnostics. And then we also need to balance that wound environment and normalize healing. So there are a few ways that we can do that. And I think most of us who have done wound care are very familiar with these four concepts. But perhaps sometimes it's really good to review, because we do get into the practice of doing things a specific way. And sometimes there's reasons why wounds do become stalled out. So the very first one, of course, is wound bed prep. We know how important wound bed prep is. and necessary in order to help. Number one, we want to get that wound bed primed to give it the best possible healing trajectory possible. And then we want to make sure that we have proper debridement. So we need to remove that necrotic or devitalized tissue. We know that this is absolutely necessary in order to provide the best healing environment. And we can't go any further without talking about exudate management. We know that exudate can delay wound healing. It can severely affect a patient's quality of life. And this is where we start getting into that patient-centered piece. So we're going to talk a little bit more about that here in just a minute. It can have significant socioeconomic impact. The amount of exudate can either be very excessive or it can be insufficient, so the wound bed isn't moist enough. The composition can be abnormal, so we can have a very thick exudate that is not allowed to flow through a dressing, or that exudate can be in the wrong place. Maybe there's issues with the gravity or location of the wound, and so you'll get pocketing of more fluid in some areas than others. And then finally, dressing selection, last but not least, extremely important, and we really do need to understand how our dressings are working. So most of you are familiar with wound bed prep. There's several different models out there. I think you've probably heard of time, which is now timers, and that includes not only that tissue debridement as well as infection control or inflammation control, moisture balance, edge of wounds, so where you're actually trying to make sure that the peri wound is being well cared for, making sure that those edges are in proper alignment with the wound to allow it to heal, but also regeneration and repair of tissue. So this is when we're looking at some of those more advanced therapies, perhaps hyperbarics or perhaps skin substitutes. There's so many new technologies out there now to help. So this is where we're looking beyond perhaps just our products that we're using in our daily practice and looking at some of those advanced therapies. And then finally, social factors, which I think is last but not least. I really like this model where we have the wheel and in the center, we talk about social because ultimately that is the key to all things. We can't help address all of these other factors without actually looking at the social factor. Now, earlier we talked about MMPs, and I think it's really important to understand when I first saw this document, it reminded me of how important this concept was. I know we talk about MMPs all the time and how they're good or they're bad and how we don't want to have too much in the wound bed, but how do we actually control those MMPs? Well, believe it or not, there is data out there to show that there are ways to control MMPs. And when we look at this model that came from not actually from this paper, it actually came from another group, and it was out of a paper about biofilm. And they were talking about things that are required in order to help reduce these MMPs. And specifically, they were looking at the action of SAP containing dressings or that super absorbent polymer dressing. And this was actually published in 2020. But what they were talking about are the key factors of absorption. So absorption is really important to help with the uptake of those bad wound inhibitors, those things like MMPs and those excessive protease levels, getting rid of some of that bacteria in the wound. Well, then they looked at the next step, which was sequestration. And sequestration is where there's an actual uptake and those things are locked away inside of the dressing. Retention, so sequestration, obviously very important, and retention, equally important, because that's actually holding those things in the dressing instead of allowing it to go back into the wound bed. And then finally, whenever you remove an SAP dressing, you're actually getting rid of those MMPs, and obviously they can't re-enter the wound bed. The big difference between this and maybe some of the other products that you have used in the past, I know myself, I was always a very heavy foam user, and I really didn't think about this concept until I read this paper. But if you're looking at a foam dressing, we know that a foam dressing can sequester, and it can also retain some of that drainage, right? Because of how it's layered. But that very first layer that's actually touching the wound bed, it is kind of like a sponge, and it allows fluid to go in and out of it. And if you were to squeeze that dressing, you would notice that you could wring a little bit of fluid out of it. Well, think about how that's working for your patient. So if that fluid is going back into the wound bed, what else is going back in there? Yes, your MMPs and some of that bacteria and some of those inactive growth factors and other things that we don't want inside of our wound bed. And there's actually been some studies shown that with SAP type dressings, that they've been able to bring those wounds from that chronic state back to an acute looking state by removing those MMPs and other wound inhibitors. And we're happy to share that with you. I'll give you some information at the end of where you can find that. So what do we really need? What do we really need in our dressing selection? So we need a few things. First of all, we need to make sure that we're using something that can help reduce those wound inhibitors and allow for wound healing. So we want to make sure that it can bind with bacteria and help retain those MMPs. The next thing that we want to do is we want to make sure that it can balance the microclimate. And I know that we have a lot of different ways of doing that. It's really important to select a dressing. I kind of think of it as being a smart dressing, because the way that it works, it can allow fluid to either the appropriate amount of fluid to stay in. So meaning that you can have a nice balance of fluid. If you need more fluid, then you're going to have that moisture allowed to the wound bed. Or if you need those things taken away, like whenever you have moderate to heavy exudate, you start looking at your SAP dressing. And then you want to protect the wound. And there's a lot of talk about how we can help control pain in a lot of different settings. And when I think about our hospice and palliative care settings, especially, this becomes even more important. But we want to make sure that we can have the least atraumatic removal. We want to make sure that we can have the least painful dressing changes. We want to make sure that those dressings are soft and comforting. And we also want to make sure that they can help provide a barrier for viruses and for bacteria and other infectious products. So next we're going to talk about my favorite part, which is balancing patient care. And again, we're looking at multiple areas on this wheel. And again, you see that they're very integrated. But again, we're looking at that patient-centered assessment and diagnostics, and then also balancing that environment. And when we start looking at patient care, there's a few things that we know. We know that our patients all have very different stories. They all come from very different backgrounds. They have different resources. They have different people that they can rely on, or maybe no one at all. Maybe they qualify for home health, or they don't qualify for home health. Maybe their living conditions aren't up to par to help them stay healthy, or perhaps they have all the resources that they need. But every single person is different. And so we want to make sure that we understand what's going on with our patient. And that's really how we get back to the patient-centered care piece. We want to make sure that we understand and listen to our patients and their caregivers, especially if they're some of the main providers of care for those patients. We want to understand their lifestyle, and not just the lifestyle that they're doing because they have a wound, but what about the lifestyle that they actually want to live? And then we also want to make sure that we're addressing those physical and psychological factors. And I don't know how many of you follow some information that's been coming out lately where they are talking about isolation, specifically in the elderly population, and how that's contributing to a lot of these health issues. They've seen it happen even more after the pandemic. So these are things that we have to take into consideration when we're providing care, and especially when we're providing wound care, and we know that this is going to be an ongoing care process, and we have to be very involved with these patients. So how do we get involved with our patients? Well, there's a few ways. I like to think that we do a pretty good job of hearing our patients out. And you can tell that we do this when we go back to talk about our patient stories. For myself, whenever I'm working with a physician, I may go into that physician and kind of give them a quick rundown that, I talked to Mr. Jones. These are the issues that he's having. His wife is out of town for the next month, and so she's not going to be able to help him. Perhaps I know that he recently lost his job, and so his insurance is changing. These are things that I might share with my provider, but am I really asking the questions that my patient needs to know in order to understand what their priorities are? So when we start looking at these types of questions, we want to start asking, what are your actual goals? One patient story, this just really touched me because a patient, all he wanted to do was to go to work and be able to stay a whole day at work and spend his whole shift working without having to go back to the bathroom and change his dressing 3 to 4 times a day. That goal is very different than somebody else who's walking in to say, I just want to heal my wound. And their lifestyles are very different. So we always have to be mindful of what our patient priorities are. I think another really great example is when we look at hospice and palliative care, what are their real concerns? So I know oftentimes we think that we're not trying to heal a wound, but if we have that intention of healing a wound, we can help those patients with their odor control, exudate management, being able to spend more time with their family because they're not having to go through so many dressing changes or embarrassment. So all of these things are really important to understand, and they're going to help us get on the right track with our patients. So now, when we look at the patient-centered approach, guess what? It's not just about us. It's also about our patients. And we do have to define who has ownership. So as a clinician, I may have ownership on helping my patients to get the right resources and the right care and making sure that we're providing evidence-based practice. But at the same time, my patients have a responsibility to help move forward with that treatment plan. And I need to make sure I'm doing everything that I can to provide the opportunity for concordance with that treatment plan. We need to set the right expectations, both from our standpoint, but also from the patient's standpoint. And we do that, again, by helping to prioritize their goals rather than just our goals. We want to use uncomplicated language. This is one of my favorite challenges. I love educating patients and caregivers, and I love to break things down to very, very simple formats. Sometimes I'm talking to somebody who I might be describing how to apply a dressing and talk to them about it in terms of plumbing because it makes sense for them. So, we have to get creative in this area to make sure that our patients understand and that they can actually show us that they understand. We need to look at those intrinsic and extrinsic factors. And then finally, educating the patient and caregiver. And we need to consider their literacy styles. Everything from the opportunity now, obviously, maybe years ago, we never would have dreamed of putting QR codes on everything. But now that people have gotten used to it, it's a very simple way to communicate and have those videos at people's fingertips. Or perhaps people just like the old-fashioned method of talking it through and show me how to do it and I'll do it too. So we just need to make sure that we're supporting whatever that learning style is. So patient care is extremely complicated. We know that the wound itself has its own impact on the patient's quality of life. So when we look at this, we're talking about odor control or exudate management. I mean, certainly people just want to be able to have the opportunity to do the normal activities that they need to carry out in their life, or maybe it's mobility. But then we also see the social factors, and we see that living environment, their hygiene, their financial resources, the financial impact. So again, going back to that gentleman, so what happens to him if he has to continuously change his dressings at work, and now he's not able to carry his weight at work? Perhaps the impact may be him losing his job because he's having to be out so much. Then what happens? Now we go into this vicious cycle because we're going back to now this patient doesn't have the financial resources. And so now we have to relook at how we're treating his wound, and hopefully it doesn't deteriorate because of these impacts. So I like the circle in the middle because it really is a constant motion or constant cycle of making sure that we're looking at both the wound and the patient and their environment and their resources all at the same time. And last but not least, quality of life. So we know that a wound can definitely affect a person's quality of life and their families and caregivers. But how do we actually put a metric on that? And like I said earlier, I think we're all really great at telling those patient stories, and we can do a good job with that. But at the end of the day, there are other ways for us to actually review the quality of life with those patients. And we need to have a set way of actually communicating that. For me, I think out of all of the tools that came out of this paper, this one was really important. And I think this could be well implemented. So when we look at quality of life, what are we actually doing to figure out where that patient's at? So what's their baseline when they come in to see us and we start providing wound care? And where are they going? And where are we going to help them get there? With something like this tool was actually, it came out several years ago and it's been updated. It used to be 17 questions and now it's down to 14. Really, you're supposed to do it every week that you're taking care of that patient. It's a very short questionnaire. It's been validated in several languages. And what we want to do is we want to take a tool like this. We want to get their baseline, and then we want to continue using the same tool to see if they're improving, if they feel like they're improving. If they're improving in any of these areas, then we know that we're on the right track. Now, we may see that their wound's improving, but if they don't feel like these areas are improving, we're still not on the right track. We need to make sure that we're all on the same page. The other piece to this is that it gives us an opportunity to tell that patient's story through the patient's eyes. That's extremely important. And no matter what care setting that you're in, we all know that there is a risk of litigation. So what happens whenever you stand there and you provide a testimony about what happened with this patient? So how are you going to recall their story? Well, one way to do this is by using a tool such as this questionnaire. Maybe there's other ones out there that some of you have used. Most commonly, I hear that people are not using one at all. But imagine that you're standing in front of an opposing attorney and you're able to say, here's the patient's story through the patient's eyes. And this is what we found. They said that their wound was improving or their life was improving, and we know that we were on the right track. That's a totally different story than what may be offered by that opposing counsel. So just keep that in mind. Another thing that I think was really fantastic about this paper is that the concepts were actually very straightforward. None of these things are complicated. They're things that we probably all know, but maybe it's just been a long time since we've put them together. And I know that we've often talked about going back to the basics. Well, this document has also another tool that comes along with it, and it's an infographic, and it just helps provide that information so that you can share this with others if you want to, or you can review it on your own. So where are we going with all of this? Obviously, we want to share with you that ZetaVit Plus and the ZetaVit Plus family, ZetaVit Plus silicone border specifically, helps to offer a lot of the things that we talked about in this presentation today. So we know we can balance the microclimate. We can reduce inhibitors to wound healing. So we're helping with those MMPs. We want to bring that wound back from that very chronic or stalled out looking state back to that acute looking state. And we also want to make sure that we're protecting the wound. So how do we do this? Through the eyes of wound balance, we can use our ZetaVit Plus family of dressings for effective, versatile, and patient-friendly care. I don't know how many of you have seen the newest version of our products, but it just came out in August, and now we offer different shapes and sizes. We have reduction in risk for leakage, strike-through, and odor. It stays in place, so up to 7 days. The other thing that's really important to understand is because they're SAP dressings, they are also frequently covered for 30 dressings per month. So keep that in mind. So if you need to work with that patient and have them have a daily dressing change, And then perhaps you can start reducing it over time. You can use this dressing in a very versatile way from daily all the way to 7 days, 7-day wear time. And it's very comfortable. So keep that in mind whenever you're thinking about that patient's quality of life. The other thing that I just want to share is that we have multiple new sizes and shapes. So these are the newest ones that are available. And then finally, I do want to say thank you. I'm going to open it up for questions here in just a second, but there is also a QR code located here on the thank you slide. This QR code will take you to Link, which is our educational website. And there you'll find more information about wound balance. You'll find more clinical evidence. You'll find information about webinars and CE programs, but you're also going to find the document that we talked about today. You can also find the infographic at that location, and we'll keep you updated there.
Hi, we're back. Okay, so I have been monitoring the slides here, or not the slides, the chat. And we do have a couple of questions here. We have a question from Dane. What other wound care product can be used and work well alongside superabsorbent dressings like Cetaphil?
Sure. Well, I'll tell you. So whenever I think about the different ways to use this, it really does depend on the care setting, because sometimes unfortunately, we're all tied to the financial situation that our setting allows. I've seen this dressing used all the way, and I've used it myself, all the way from helping to provide, maybe it's under compression, so I'm not using the silicone version whenever it's a heavily exudating wound and we're just putting them into compression. So I see it used alongside compression, as well as collagen products. For us, we have our Colactive Plus and Colactive Plus AG, and we have it in powder forms. I've also seen it used alongside, just tons of different ways. So in palliative care, I've seen it used to help protect a fungating tumor or a tumor that is obviously part of end of life, and just to help protect that area and manage that exudate. And then I've also seen it used, which I think is probably the most interesting way. We have one podiatrist that works with us often, and she provides us information about how she's using the product. And for her, she uses it because, again, it's available for up to 30 per month. So in the beginning, she's using it while it's heavily exudating, but as that wound starts to heal, she then is able to use those dressings to help protect the wound later on as it's in that final stage of healing and epithelialized. So I've seen it used in a lot of different ways and with a lot of different products. If you're using a enzymatic debrider that's supposed to be changed daily, then I've seen it used with that. So I hope that helps answer a couple of those questions. So obviously it's very versatile.
I have a question here from Sarah. She asks, what is the best option for someone with a wound but who has fragile skin? Been having trouble with certain adhesive products we've been using, irritating the skin.
Yeah, so Sarah, what I will share with you is obviously every patient is different. So that's where I'll start with. But what we do know is that out of all of the adhesives and products that are out there that may potentially stick to the patient, we do know that the silicone-based adhesives, so like the silicone that you would find in Cetaphil Plus, is the least traumatic type of product that you can have as far as what you're using on the wound. The really great thing is we also have Cetaphil Plus without silicone, and so if you're just trying to protect that fragile skin, you could use that as well with just perhaps some kind of gauze roll or some other type of wrap if you needed to.
All right, we have another question from Jillian. Well, this is a big question, but or kind of a pretty general one. She asks, my husband has a shallow, stubborn wound on his leg, and we can't get it to close up. What options would you recommend?
So Jillian, the first thing that I'm going to say is I'm going to take the patient-centered approach. So this is where it becomes really important. You know, obviously I cannot give you advice in this situation, but what I will say is for a patient that has a stubborn, shallow wound, the very first thing that I want to do, I want to understand what type of wound that I'm looking at. I want to understand how long it's been there. I want to understand what I've used in the past. But then if I just didn't know anything about this wound, I would look at using something that could help with those MMPs, because usually if a wound is lingering, we know that those MMPs are elevated. So in this case, for myself, I'm going to reach for one of the Zedivit Plus dressings. I would probably consider using, depending on the amount of drainage and if this person needed compression, which is quite possible. That would depend on which one I would use. So with compression, I would use without silicone. And if I didn't need the compression, then I would definitely use the silicone-based product for easy removal.
All right. Well, we're almost out of time here, but let me I'll keep an eye on the chat if we have any more questions. But I do have one here from our Medical Monk staff as well. A core tenet of wound balance approach seems to be taking the patient's mental health into account. In the future, do you see mental health clinicians taking some role in the wound healing process?
So I love this question, actually. So yesterday I was actually at a smaller conference. It was a more regional conference in Jacksonville, and it was all about taking that patient-centered approach. And yes, mental health was definitely a huge part of it. They talked about everything from meditation and prayer to cannabis, which was a new concept for me. but you know, I guess to each their own. But mental health, yes, absolutely, and that was a topic of discussion. And I think as you know, we see our patients are getting younger and younger in wound care, and those stress factors are very different than probably what we've seen in the past. You know, maybe in the past we were looking more at like caregiver stress and dementia and things that might be inhibiting that wound healing. But now, I mean, isolation, huge factor. So absolutely, mental health is a part of this.
All right, great. Well, I don't think we have any more questions here, but all right. Well, I think we're about ready to wrap it up then. Thank you everybody for coming here. If anybody, you know, wants to see any of this information again, you can. We're going to be sending you an email later today with a link with the recording of this. Also, want to remind everyone that Zedivit and all other Hartmann products are available on our website, medicalmonks.com, at fantastic prices, of course, as always. And if you have any questions just specifically about products, you can also always contact us, customer care at medicalmonks.com. Give us a call. And is there anything else, Chrystalbelle, you'd like to?
What I would love to share with you all is this concept of wound balance, because it is about the patient-centered approach. We are finding so many different areas where this topic is a huge discussion piece. And so I would just say, continue to follow us. Again, I gave you the QR code earlier. We can send that with the email as well. But continue to follow us about wound balance, because we're really tapping into some of those care settings that maybe don't usually have a voice. And I think wound balance is really helping a lot of different areas to have that voice that they really need. So follow us and keep in touch with us with Medical Monks. We're very appreciative of this opportunity, and thank you, Adam.
Yes, thank you so much, Chrystalbelle, and everybody have a great day, and we'll see you again soon.
Thank you.